This week is an important week in cardiac rehab because now I'm going to have a lecture that's going to go over all of those competencies that we've been reading about in some of your previous assignments. Understanding why we have these competencies, how they're diagnosed, how we recognize them, and what we do with them. And we're looking at them as risk factors, right? So what types of behavior modification do we need to make based on someone's positive risk factors, what risk factors they present with? So some of the important things that we do in a phase 2 cardiac rehab setting is we begin with an assessment. So the patient is referred by their cardiologist, maybe their thoracic surgeon, maybe their pulmonologist. So they're referred to the clinic. And then you, the case manager, the exercise physiologist, or the nurse, or together, are going to do an assessment. And what we're screening for is to get as much about the patient's history as we can. Tobacco use, dyslipidemia, right? So cholesterol, lipids, hypertension, physical inactivity, diabetes, psychosocial concerns we may have, obesity, and any other emerging risk factors. All of you openly shared your confidence with certain risk factors and areas of a little bit concern that you haven't felt your academic classes previous to this have really done a thorough job in exposing you to competencies. Those students that have already been in a practicum or internship out in the community seem to have a little bit more confidence because they've met more people, they've been in secondary prevention programs, some of you cardiac rehab centers. If you're not yet ready to go and do that off-campus practicum or internship, then we have a lot we still want to cover in the class. So when you think about the initial assessment, right, all of the things we want to get at is who is this client that's been sent to rehab. A physical assessment, be able to get information on their angina, the pain that they felt. You want them to tell you where anatomically they felt that discomfort, their chest, their neck, their jaw, right? It's what we call ischemia. So obviously the patient's not going to know what that word ischemia means, but we want to ask, where were you symptomatic? What were the signs that your body communicated prior to the heart attack or prior to having the stent or the open heart done? How often have you felt that your shortness of breath, right? Do you find it when you're sitting, doing nothing, with mild exertion? Are there any times that you feel dizziness or syncope? You feel like you're, kind of seeing black spots and woozy a little bit? Orthopnea or paroxysmal nocturnal dyspnea is shortness of breath with changing positions, or that wakes you up in the middle of the night, right? So that shortness of breath that changes with positional changes, ankle edema, swollen ankles, swollen extremities, so fluid overload that you can test and see. If we're in a lab, I would show you how to stage or classify pitting edema. Palpitations, tachycardia, racing heart, intermittent claudication. Then remember that's that fancy word for vascular disease in the legs. So intermittent claudication's leg pain, right? Leg pain due to hardening of the arteries down in the extremities and low blood circulation. So it's ischemic leg pain. Do they have a known murmur? And many of you don't yet know how to listen to heart and lung sounds. But again, that's something that's going to evolve with more classes and more time out in clinics and internships. So heart murmur, unusual shortness of breath or fatigue with physical activity. So when we are screening our clients, right, each of these in a rehab setting, right, this is a secondary prevention exercise setting, they have known disease, they've been referred to us by a physician. Our job now is to write an exercise program, but in order to do so, we really need to assess all of their baseline information. What conditions are well treated? What is still not treated? What can we recognize as really needs clinically significant risk factors that we want to come up with a plan? For those of you that are still, or not still, but are working with primary prevention people in the community, right, our screening is a little different. We're looking at people that probably maybe don't have known disease. But either way, primary or secondary prevention programs, right, this class is secondary prevention, but I want to let you know, in order, either of them, we want to really have a good feel for who your client or patient is in order to write an comprehensive individualized prescription. So risk factor management in combination with other known disease, cardiovascular, renal disease, metabolic disease. We then If you're out in the community, do you need medical clearance? Do we need to exercise test? Do we need supervision? In this class, they've all had medical clearance because they've been sent by their physician referrals. All of them are going to have a stress test done day one with you in the clinic, unless they happen to have just had one in the doctor's office, which they'll send to you. And then supervision. Obviously, everyone in cardiac rehab has to be medically supervised with an EKG telemetry. This is one of my favorite pages in the ACSM guidelines book. It lists the key risk factors, right? So on the one column, we've got the risk factors, and then we have how do you define them. And I feel like this is where most students need to go back and review. Just because we say someone has family history, what does that mean? Just because we say someone has hypertension, what does that mean? So I want you, in your little guidelines book, look it up or blow up the slide so you can see the font. These are what are risk factors. Then down here is an interesting thing. It says negative risk factor. There's one element of doing somebody's assessment that you may get some good news, and that good news would be a negative risk factor. A negative risk factor negates one of the positive risk factors. So a negative risk factor is a good thing. A negative risk factor, the only thing that's listed as a negative risk factor is HDL, high density lipoproteins. You know this as your good cholesterol. So somebody who has cholesterol greater than 60, that's a positive. That means that body is making a lot of HDL cholesterol, and the HDL cholesterol is a molecule, the cell or molecule that can pick up the fat, can pick up the lipids, and help clear it through the blood. The thing about HDL is we only, the younger we are, the more active we are, the higher your HDLs. So the more we get people to be active, the higher your HDLs. However, most people don't have high HDLs, which is why, it's kind of a positive thing. It kind of negates one of the other ones. But I want to look at those risk factors in this table above, right? So age, men and women have a specific age. So go back and look at that. Family history is very, very specific. Family history is looking at sudden death or heart attack before the age of 55 in men, or in women before the age of 65. Very specific. This is not my second cousin twice removed. This is not my stepbrother, right? This is direct first line family members, right? So mother, brother, father, sister. I said that kind of funny. Cigarette smoking, if they've not quit, if it's not been more than 6 months, they are still a current smoker. Sedentary lifestyle, I think that's the one you all know how to define, right? So not participating in 30 minutes of moderate activity. At least 3 days a week would be classified as sedentary. So 80-90% of our society would be classified as sedentary. Obesity is a BMI greater than 30. Take a look also at the waist circumference. So men greater than 40 inches, women greater than 35 inches. Hypertension, we'll talk a lot about that in a minute, right? So hypertension, that is systolic greater than 140, diastolic greater than 90, or it doesn't need to be both numbers, and or those numbers, or somebody who's on medicine, right? Or they're on an antihypertensive medication. Dyslipidemia, the cholesterol levels. So LDL greater than 130 is not good. HDL levels that are less than 40, which is opposite to how I just started talking about good HDLs are better than 60, bad is less than 40. So dyslipidemia is a really big one. Or they're on medicine is another one. Or their total cholesterol is greater than 200, and pre-diabetes is so important. We're going to talk about this a lot as well with metabolic syndrome and looking at resting glucose levels that is impaired, which would be fasting levels higher than 100. So I'm rattling off so much information on this slide. I want you to go back and read these. I'm going to go through them as we begin right now with hypertension. So we call this the silent killer because today, sitting here listening to me, you cannot tell what your heart rate is. Our body doesn't sense our blood pressure. Sorry, I said heart rate, blood pressure. So it is a problem, right? Millions of Americans are undiagnosed. Hypertension is going to double the risk for cardiovascular disease with each increment of your blood pressure greater than 20 millimeters of mercury systolic or 10 diastolic. Underlying cause, oftentimes we don't know, but it is really considered the silent killer. We define it as 140 over 90, or, not both numbers. What happens when someone has hypertension? We have an increase in cardiac output. results from increased peripheral vascular resistance, and this damage, all of this piping, all of the vascular system becomes very damaged. Endothelial lining is damaged. We have a higher risk for stroke and heart attack, MI. Increased myocardial workload from hypertension leads to hypertrophy and enlarged ventricle. Enlarged ventricle is not good. We end up being much more ischemic. So when you think about ischemia, it's lack of blood flow. So we're not getting the blood we need to the heart. It's on overload. The heart is overworking. We see a lot of ectopy, which is irregular heartbeats, irregular EKGs. Over time, in many years, people end up with congestive heart failure. Medications are needed. Even though somebody is not symptomatic with hypertension, we need to screen their blood pressure, which is what you all should be doing in your fitness facilities. Screening clients, if anyone is 140 or 90, medication is really, really an important thing. Exercise, individuals with hypertension should have a medical evaluation before exercise testing. We want to watch how the blood pressure responds to increasing workloads of exercise, right? Exercise is stress. So people who are planning on vigorous exercise absolutely need to understand. So I hope that all of you can define moderate versus vigorous exercise. I kind of jumped the gun and didn't explain that to you, but I want to make sure that that's something that you are aware of. Normal blood pressure should increase with increasing workloads. However, we don't want somebody's blood pressure to go above our threshold guidelines, which would be 200 systolically or 110 diastolic. We call that a relative contraindication. If it continues to rise and it becomes 250 or 115, so systolic or diastolic, we absolutely need to stop exercising. So contraindicated can be, again, relative or absolute. This depends on who the person is, who the client is, who you are as a clinician, where you're working, what we know about the patient. Are you in a medically supervised state? Do we already know this stuff? But when in doubt, we stop, right? So that's excessive rise in blood pressure. People who are already on a medicine called beta blocker are going to have a delayed heart rate. You probably already knew that coming into this class. So an attenuated heart rate response to exercise is going to change how we prescribe our program. So many of our people with hypertension are on beta blockers. It's a very common thing. Most of our patients in cardiac rehab are on beta blockers. So we're going to have to take a look at heart rate response as we get into the exercise prescription in a few weeks. But again, we want to know when we need to stop exercising when blood pressure becomes excessive. So adequate control of blood pressure before beginning a resistance training program is absolutely imperative. So aerobic versus resistance training. Resistance training is something we need to have good control over blood pressure, which means they might need a change in the medicine, they might need to get on medicine, they might need more milligrams of the medicine. We cardiac rehab people need to be in touch with the referring physician about what and how blood pressure is responding to make sure that they're safe to begin resistance training program. So with resistance training program, we're going to begin low, lightweight, low repetition. Post-exercise, so you've got a client with hypertension. I want you all to realize that the post-exercise cool down is imperative because these are the people that end up passing out post-exercise. They have a plummeting drop in hypotension. Why? Because the medicine they're on is a vasodilator. That's what blood pressure medicine does. It vasodilates to bring the pressure down inside those arteries. But you've got to remember that aerobic exercise is a natural vasodilator. So now you have medicine vasodilating, you have aerobic exercise vasodilating, and post-exercise, plummeting blood pressure can result. That is why you never skip a cool down in cardiac rehab or in your fitness facility with people that are higher risk. So that active cool down is going to keep those muscles contracting. So let's say, the guy just finished doing his 30-minute aerobic exercise program with you. Now we're going to keep him on the treadmill, on the bike, and those muscles are going to continue. The gastrocnemius, the soleus, the glutes, the hamstrings, everything is going to continue contracting, and that contractility of the skeletal muscle is going to continue squeezing the venous blood back up to the heart. So what the venous blood flow return to the heart does is it keeps the person from getting lightheaded and passing out and hypotensive. So with hypertension, you must cool down. I also want you to measure blood pressure all the time, before, during, and after exercise. We are taking blood pressure a lot. Get really good at doing exercise blood pressures because most people are not well medicated. So we want to get them medicated, get the blood pressure under control. It doesn't mean they're going to be on medicines for the rest of their life. Oftentimes, as they get themselves in better shape, many times will even lose 2, 5, 6 pounds of body weight. Little body weight can have a drastic change on blood pressure numbers. So we really want to initiate blood pressure medicine. So when you think about disease-specific effects, the physiological response to fitness is blood pressure, exercise response for the systolic blood pressure and diastolic blood pressure should be stable. Systolic should rise, diastolic usually goes down. How much does systolic rise? For everyone who's healthy, it's around 10 millimeters of mercury per MET level. Patients with heart disease oftentimes doesn't do that. It's variable response. So with heart disease, cardiac rehab obviously is heart disease patients. We can see exertional hypertension, like I just talked about, where it jumps up really fast, or the opposite, guys, like I just mentioned, exertional hypotensive can be seen as well. When you have a patient with either exertional hypo or hypertension, their mortality risk is very, very increased. So it's going to relate to increased cardiac morbidity and mortality. These are the patients we want to watch a lot. So warm up and cool down is important. Measuring their blood pressure is important. Is really imperative. I've got 2 slides, and if you've had me before in a class, you know that I love these slides. I am really specific and anal about how people do blood pressures, where they put the cuff on, where that stethoscope goes, how the stethoscope earpiece goes into your ear, how much you inflate it. Are you actually hearing the number that I hear using a double scope? Many students ask me why we don't use automated cuffs, because automated cuffs simply do not work effectively when the body is moving. If you're a nurse lying in the hospital, you can do an automated cuff. But we really want to do manual cuffs. You need to really train your ears. It's a lot of coordination with what you're hearing, what you're seeing on the sphygma monitor, how fast you're releasing the valve. You want to release it slowly, how extended the person's arm is as they begin flexing that elbow. The artery begins dropping. It's not as superficial, so have a very good straight extension of the elbow joint so that artery is lying more superficial. I am not going to read these to you, but if you've not had me before, I want you to read so they make sense. Or you really want to make sure that you do each of these steps and always verbally say out loud the blood pressure. So exercise blood pressures are hard to do. There's a lot of pounding on the machine, especially on the treadmill. There might be music playing in the background, right? The patient might have bad balance and not have a struggle taking his hand off the machine. So there's lots of things that when you're in your internship and your practicum that you're going to get good at doing, and this is really one of them. But classifying blood pressure is the other thing we want to know. So anyone who is above 120 or above 80, really you want to watch. So if your blood pressure is above 120 or above 80, we're what we call prehypertensive. And as we see with increasing age, increasing weight, sedentary lifestyle, stress, it just simply elevates. Again, it's the silent killer. It's doing a lot of damage inside. So what are we advising for the behavior modification? We are advising that they're active, they are moving. Nobody should for sitting for more than 2 hours. Decrease sit time, get them moving, increase steps, ideally aerobic exercise, weight reduction, and there's a lot of pullback on weight reduction. Weight reduction works. Yeah, somebody might need to lose 50 pounds. Yes, and I might not get that 50 pounds off, but if I get 5 pounds weight off, you are making progress with seeing a difference in their blood pressure. It doesn't need to be dramatic, even though they probably have a lot of excess fat to lose. Small amounts of weight loss goes a very long way physiologically with reducing blood pressure. DASH diet, really being aware of what the source of the food is, that it's healthy, natural food. Sodium is a big one. Moderate alcohol consumption. So the Joint National Committee on the Prevention, Detection, and Evaluation of the JNC7, which is quoted and cited in so many journals and textbooks, tell us really where we need that blood pressure to be, and really when lifestyle modification needs to be activated and when blood and medicine needs to be activated. So being on a medicine is okay. Many times the beginning might just be a diuretic, a water pill to try to get that blood pressure down. Getting people active, getting them out of a chair also can really be beneficial. So this is one risk factor that you probably already knew a lot about. The next one is diabetes. There is so much for me to teach you about diabetes. I mean, it really could be a class in of itself. Diabetes is rising in cause of death. We're seeing increase in diabetes among all ages. We used to call it, we used to have type 1, type 2, and gestational. Well, we still do have those three, right? Type 1 is someone who immune system has kind of been broken. It's oftentimes early childhood where the pancreas has broken, right? So the fail of the pancreas. Type 2 used to be called adult onset diabetes because you used to get it later on in life. But they've dropped that term because our pediatric obesity is so systemic that we are seeing children 5 years old, 8 years old with a condition that used to be for people over the age of 40. Because the more fat you have, your body becomes resistant to insulin. So the body is still producing insulin, which is unlike what's happening in type 1, where the insulin is broken, it's done, you're taking insulin shots. In type 2, the fat, the problem with why people have type 2 diabetes, number one, they have too much fat on the body. Number two, they're sitting too much. Those are the two reasons why we get type 2 diabetes. Their muscles are not moving. If you're not moving your muscles, you're not uptaking glucose. The glucose becomes elevated, and now you're resistant to having the insulin do its job and uptake that glucose. The other reason is fat, right? The more fat we have, the imbalance we have with that glucose system. And then gestational diabetes, I'm not going to talk much about that, but that is with, obviously gestational diabetes is during pregnancy. The problem with gestational diabetes is once they deliver the baby, oftentimes it will subside, only to come back later on midlife as type 2 diabetes. Why diabetes gets so much attention is because elevated glucose levels is an absolute bear in the body. I mean, it is absolutely changing the way the pathophysiology of organs are working. And as you see by my list in front of you, it is very head to toe. There are going to be problems. So from retinopathy to nephropathy to neuropathy, hypertension, lipids, heart disease. So you see early onset eye disease, you see kidney damage, you see heart damage, you see increased risk of stroke, right? You see neuropathy with balance problems in fingers and dexterity. So this is the difference between type 1 and type 2. I want you to focus on type 2 because as a nation, this is what we're battling. We are battling type 2. There is a lot of myths that happen with the older person that's on insulin injections. Oh, they'll say, I have type 1, it's okay. No, it's not okay when you're later on in life and diagnosed with type 1. It leads to really severe type 2, where now the body is so resistant to insulin they may be on injections. But type 2 is really what I want you to focus on with as you're learning to deal with how to prescribe exercise with diabetes. So the thing about diabetes is it also affects blood pressure. So as you noticed on a few slides ago, I talked about 140/90. Now the number has changed. With diabetics, with anyone diagnosed with diabetes, type 1 or type 2, to control hypertension needs to happen earlier. We never want our people with diabetes to have a blood pressure above 130 and above 80. Much more stringent guidelines, a lower threshold for what we call hypertension. So hypertension is defined differently, as you see on the slide, 130/90, with diabetes. With diabetes, we must monitor fingertip, get those little finger strips, and you want to see the patient before exercising. So type 1, most common concern is that they drop, they get hypoglycemic post-exercise. That's a common thing with type 1 is they're on insulin and then they're going to exercise and then they're going to plummet. If that's the case, this is not a common thing, right, type 1, but if it is, we want to make sure we're looking at their food. So this is where we work really close with counting carbs and making sure they're intaking the right amount of carbohydrates before exercise. Type 2, our big issue is they're too high. The glucose level is too high. We call that hyperglycemia. So what does exercise do to the body? right? Exercise is going to utilize glucose, right? The more your muscles are contracting, the more they're eating glucose, which is why exercise is good for diabetes, because people are walking around hyperglycemic, high sugar levels. So the more they exercise, the muscles eat up the sugar and their glucose levels come down. So cardiovascular, lipids with cholesterol, anthropometric, their body composition, metabolic, which is insulin sensitivity, psychosocial outcomes, all of these things have beneficial outcomes. When prescribing exercise with diabetes, we want to screen, as I mentioned. You want to make sure before exercise, everyone is at least 100 or above. What is 100? Their finger stick, their blood, right? Their blood finger stick. So you poke their finger, right? Put the little plop of blood on a little, I can't even think of words right now, and the little monitor is going to measure how much glucose is in their system. If they're hyperglycemic, it's too high, we can have them pee in a cup and do a ketone strip to see if there's ketones present. So the other things, we want to look at how high or how low are they to know if they're safe to begin exercising. We do this in rehab. The other thing we want to look at is neurological. So a lot of people, and this might be new to you, listen, a lot of patients with diabetes have what we call autonomic neuropathy. It's not written, but write it down. Autonomic neuropathy means that they have neurological problems. It means that the autonomic nervous system has neuropathy, nerve damage, and what that means is they had silent ischemia. So you know what ischemia is. It's lack of blood flow. Most people who get ischemic get angina, chest pain. Many diabetics, however, because they have autonomic neuropathy, they end up with silent ischemia, meaning they don't feel their angina because the neuropathy is set in. Does that all make sense? So someone who has silent ischemia is a very high-risk patient while you're exercising because their body may not mimic, right? They may not produce angina symptoms that say, hey, I'm ischemic. I need to be off the treadmill right now and sitting and resting. So now we're relying really on the EKG tracing. We also have retinopathy. So with people with retinopathy, you do not want their blood pressure to get too high with exercise. All of our diabetics are at much higher risk for cardiovascular and metabolic syndrome. It's very important to screen. So with retinopathy, as I just mentioned, this is vision, eye problems. With diabetes come years of retinopathy. So those little vessels that give blood flow to the eyes become damaged. With diabetes, you do not want their upper limit exercise blood pressure, systolic, to get above 170. You guys got that? So their upper level threshold is 170. You want to use the heart rate, RPE. You want to avoid the Valsalva maneuver, which is we see oftentimes with resistance training. And you want to make sure that they're talking about their eye health, getting eye exams. Dyslipidemia, cholesterol, right? The NHANES study shows that almost 50% of our population have elevated blood levels, blood lipid levels. So our goal is we want to lower LDL, and that's what most of the medicine does, right? The LDL is a low-density lipoprotein, and the higher the LDL, the more advanced heart disease people have, the higher risk they are for heart attacks, sudden deaths. So really mortality, cardiac events, hospitalization, going in to revisit with the angiograph progression. The problem with dyslipidemia is that doctors will prescribe cholesterol medicine, but patients do not like cholesterol medicine because it has a lot of side effects. So we have very poor adherence to with people with elevated cholesterol, to sticking to their cholesterol medicine. So that's something we want to really be aware of. So we know what lipids are. They're fats in the blood. Cholesterol levels travel in the blood, and they have a very distinct protein called the lipoprotein. Cholesterol is determined genetically. Believe it or not, you have a lot of genetic predisposition to your LDL, environmental factors, and health. So at your age right now, you're all healthy. I asked you to do the Framingham, and many of you said, well, I don't know my cholesterol levels. Go and get them done. Go and ask for a fasting glucose level. Yes, you have no symptoms for heart disease, but you need to know what your lipoproteins are in your 20s. Because if they're high right now, based on genetics, and you're eating a a high protein diet, depending on what kind of source of protein, you want to be aware of where those LDL levels are. So LDL cholesterol, HDL, and very VLDL. These should be a fasting blood work. In cardiac rehab, we are usually able to send the patient at least once. So they come to us day 1 with blood work, and then around week 6 or week 8 in the program, you are going to send your client to get another fasting cholesterol test, another lipoprotein test done, because we want to look at the benefit of what exercise is doing to their cholesterol levels. So that is the benefit of getting a cardiac patient in cardiac rehab, is educating them, talking about what HDL versus LDL mean. So where are they at baseline, week 1, and then where are they about, a month and a half into the program? So LDL and this one, right? We calculate the LDL, it's not drawn. So I want you to know the formula. This is the formula for calculating LDL. You take the total cholesterol, right, minus the HDL, triglycerides divided by 5 is how we get LDL. LDL is really the magic number that most cardiologists and doctors are looking at, right? So LDL is low density lipoprotein. LDL, our fats or lipids come from food. Our body doesn't really need a lot of extra fat. We usually get it just in a natural diet. But anything that ever had a face, an animal products, so eggs, cheese, dairy, milk, meats, pigs, cattle, right, chickens, right, fish, all of these things have cholesterol, right, are going to have an effect on your LDL. How effective your body is at digesting the LDL is oftentimes based on your genetic, which is why your homework should be, before the end of the semester, go and get a fasting cholesterol check done. Anyways, triglycerides, another number that you might not know a lot about, but triglyceride is a very indicative number that it has a lot of link to down the road diabetes. So if the triglyceride value is below 400, then we can divide it into what we know as VLDL. If it's higher than 400, we're not going to be able to calculate the VLDL. So what should cholesterol numbers be? In cardiac rehab, we really want them low, right? We already know we have a high-risk patient, so we want your LDLs optimally below 100. A lot of textbooks would say 120 is fine, but for a heart patient, the lower the better. Total cholesterol less than 200, lower is better. HDL, remember, the higher this is, the better. If someone has HDL above 60, that is what we call a positive risk factor. Bonus, it's going to negate one of those other bad ones. If it's lower than 40, you now have a bad HDL, right? And then our triglycerides. So the higher triglycerides, the more indicative we have down the road to getting diabetes. Obesity, I think we all know what it is, right? Obesity is something that goes hand in hand with cardiac rehab. We see it a lot. So obesity is classified as a BMI greater than 30 or a BMI greater than 25 for overweight. Excess fat plays a very, very big role on how your body is able or not able to ward off other diseases. So BMI is what's used, which is height and weight. And there's a lot of people who say, oh, I don't want BMI. Oh, I don't like it. We statistically know globally, across the globe, every country, BMI is what we're using. Now, if you say, well, I'm a tall, broad, muscular person, I don't really think I'm obese, then we're going to offset your BMI with your waist circumference. So, don't let someone talk you out of doing their BMI. No, we're using BMI. It is absolutely a valid tool. With BMI, I want you to look at their waist circumference. This is what this table does. So this means men greater than 40, women greater than 35. There's no denying if your waist is greater than 40 for men or 35 for women, you are too large. It's just the way it goes with abdominal obesity, coupled especially with your BMI values. Why are we so concerned with waist circumference? Because there's something called android and gynoid obesity. So android obesity is that belly fat, right? The android, apple, right? The apple fat. So it's the fat that is visceral right in your abdomen area. More fat in the trunk increases risk for hypertension, metabolic syndrome, type 2 diabetes, all of these things. The other one here on the bottom, this gynoid obesity, is the pear body, right? The shape of a pear. So apple versus the pear. Hips down a little bit lower, which is still not ideal. It's still not good, but definitely android has a higher risk than gynoid obesity. So where is the fat being held? So to do circumference, you're just simply going to use a spring-loaded cloth tape measure, and we are going to be consistent and measure those. I love doing circumference measurements throughout many, not just the waist. I like circumferences over multiple. And there, if you look in your ACM guidelines book in chapter 4, it'll go through all those landmarks. When you're looking to lose weight or gain muscle, circumferences is solid, right? Because you don't own a bod pod in your local gym. You don't own a bod pod in your home. So the next best thing is to just do some really good circumferences. Smoking is another big risk factor that comes hand in hand in cardiac and pulmonary rehab with older people. Tobacco use was a really big thing pre-80s. Everyone smoked pre-80s, right? And then kind of in the 80s, it was this big thing of everyone needs to quit smoking. So quitting smoking is difficult. It's an addiction. The benefit of quitting smoking is the risk of a heart attack decreases 50% every 2 years that someone has refrained from smoking, right? Cessation. The rate of restenosis following PCI, so a stent, and death following bypass surgery is decreased after people quit. And I tell you this because most old people say, well, I've been smoking for 50, 40, 60 years. Why bother quit now? Because your body needs to quit because there's so many physiological changes that will happen when we stop letting that tobacco get into our system. So to reduce the risk associated with tobacco, all healthcare providers are trained to address at a tobacco evaluation. So number one, identify, are they still a current smoker? Yes, no. Document that every encounter you make with a smoker, I've asked them, they are still smoking. How much are they smoking? Yes, no smoke. Provide the environment that facilities are repeated interventions. Have you smoked? Do you use oral tobacco products in the past 30 days, right? So are you smoking? Are you chewing tobacco? Try to reframe by that last bullet. Do you smoke or use? So have you, right? Have you used is how we word it. Encouraging patients to indicate why quitting smoking is personally relevant to them. So put it on them. And we're going to talk about motivational interviewing in a minute. Helping patients to identify the acute and long-term environmental risks associated with continuing to smoke. Helping patients to determine the benefits of quitting. Barriers is a big one, right? Why are they smoking? What is smoking doing? Is it that boredom? Is it how they deal with stress? When or how often? Where are they smoking? Repeated interventions. So I'm asking you, as you go into a clinical situation or a gym situation, to openly have a discussion about, are you still smoking? Are you a current smoker? And the best way to do this is repeated intervention using motivational interviewing. Every time, right, you want to address that client. And some of you already know about motivational interviewing and others of you don't, so I'll do a quick little plug in here, right? So the R's are relevance, risk, rewards, roadblocks, repetition. We can do motivational interviewing with everything. I am really honing in on you using it for smoking cessation. So when you think about motivational interviewing, it's expressing empathy, right, through reflective listening, developing discrepancy between the client's goals and values and their behavior, avoiding argument and direct confrontation, adjust the client's resistance rather than opposing to it. So that's an important one. And then support self-efficacy and optimism. So let's put these principles into a smoking situation, right? So the 5 R's with smoking is R for relevance. So relevance meaning encourage the patient to identify reasons for smoking cessation. Why should they be quitting relevant to them? They might say, I'm suffering from erectile dysfunction. I have COPD. I'm suffering from asthma. I have coronary artery disease, right? These would be relevant reasons why smoking needs to happen. Smoke cessation needs to happen. So identifying it, encouraging the patient to identify their own reasons relevant. I just gave you some examples. Risk. Discuss with the patients the harmful effects that continued tobacco has on their families and themselves. So risks. So spirometry, right, to estimate the lung age. attributing a typical age of their lung, their actual lung function. So that the risks that are involved with continuing smoking. Rewards, ask the patient benefits that they would foresee once they quit tobacco. So tobacco often is cost money, right? Whether they're smoking it or chewing it. So the rewards would be financial savings, obviously eliminating the odor, the stink, all of that stuff. Roadblocks, what are the barriers to quitting? Examples, stress, weight gain. Maybe they live in a household with other smokers. What are their roadblocks? What are they fearful of quitting? Roadblocks, repetition, readdress what I'm saying at each visit with all of our unmotivated smoking or tobacco users. In the AACVBR textbook, you also have access to that online. There's an appendix that's a really nice smoking history questionnaire. That's a really important tool, those of you that have personal training out in the field, that I would encourage you to use. Metabolic syndrome, this is your assignment this week. What is metabolic syndrome, right? It's a correlation between insulin resistance and heart disease. So metabolic syndrome is what they're teaching in nursing and dietitian, in medical school and physical therapy school. Any healthcare provider needs to be screening every patient for metabolic syndrome. We know that if somebody is positive for metabolic syndrome, very quickly we know their risk for heart disease is up the pipeline. It's coming, even if they don't realize it. So to have metabolic syndrome, you need to have 3 of the 5 characteristics. Okay, so now the question is, what are the diagnostic characteristics for metabolic syndrome? The patient needs to have 3 of them. So I want you to look at this first column only, the NCEP column. That's the one we commonly use. These other 2 are good as well, but most commonly I think these are the ones I want you to be familiar with. So one is size, body size. So this is for metabolic syndrome, the only thing you're using is waist circumference. We're not using BMI. So waist for men above 40, women above 35. So that would be 1. Another one is insulin resistance. So a fasting glucose, a blood value with a glucose above 110. Let me pause. To be diagnosed with diabetes, way earlier on my slide, diabetes is a fasting glucose of 100, right? Is what we're screening for. But here with insulin for metabolic syndrome, anything above 110 is a cutoff that that's not good. You would have that risk factor. HDL, that's low, and we have a gender difference number. So low for men is less than 40, low for women is less than 50. That is not good. That would be another risk factor that would be positive for metabolic syndrome. And then blood pressure, guys, this is the 3rd different number I've given you in this lecture. So classic hypertension's 140/90, right? Diabetes, hypertension threshold is 130/80. Metabolic syndrome, note this, highlight it, it's 130/85 is what we classify as elevated. So 3 of these means that somebody has metabolic syndrome. I want you to do some digging and reading. I have another file on Brightspace for you to take a look at. I want you to understand metabolic syndrome, why we use it, what the purpose of it is. Moving on, the AACVPR, right, American Association for Cardiovascular and Pulmonary Rehab, has ways that we do risk stratifying, low, moderate, and high risk. So when you're in a cardiac rehab setting, the lowest risk cardiac patients would be classified at low risk if all of these bullets are present. So it means they have no, and some of these you may not know, but to be low risk cardiac patient, all of these are not present. So they are present. They have them. So they have no ventricular dysrhythm. They have no odd EKGs during exercise or recovery. They have no angina or other symptoms of shortness of breath during exercise and recovery. Their hemodynamics with exercise are normal, right? So increases and decreases in heart rate and systolic blood pressure with increasing workloads. And they're able to exercise above a 7-MET level. My guess is all of us in this lecture, we would say, okay, that's me. I don't have any EKGs. I have no angina, no shortness of breath. My blood pressure, heart rate, everything is good, and all of you can exercise above 7 METs. Obviously, I can't see you, but I'm making that assumption. And then non-exercise findings, these are things that would be in a patient's chart, would be ejection fraction is good, which is above 50. That's how much blood, cardiac output's coming out of that ventricle. You have an uncomplicated MI, so someone had a heart attack but no complications, no complications with the revascularization, the stent, or the open heart. They have no congestive heart failure. They have no irregular dysrhythms. They have no signs or symptoms of ischemia, right, like a blood flow, and they don't have depression. So either of these two slides, this slide or this slide, is low risk. Moderate risk is different. Any one, if they have one of these present, then they are now in the moderate category. So just one of them. So this means that they might have angina or other symptoms that happen during high exercise above 7 METs. So somebody, once they get to 7 METs or higher exercising, they start complaining of shortness of breath or angina. Or you look at their EKG, and they have what we call silent ischemia. Remember, guys, they don't have symptoms. Remember, this is usually your diabetes due to autonomic neuropathy. So silent ischemia, this means that their ST segment is, changed, depressed, so 2 millimeters, that would be a flag. Or their ability to exercise is less than 5 METs. Okay, that's moderate. This would be a moderate person. Or their ejection fraction is reduced, right? So it's 40 to 49 instead of above 50. The highest risk patients would have one of these, right? Any one of these. Complex ventricular dysrhythm, so run a VTAC, right? Would be an example. Presence of angina or other symptoms less than 5 METs. So at a lower level of exercise, you're complaining of symptoms, angina, shortness of breath, dizziness. Or they have silent ischemia. High levels of silent ischemia mean that during, again, same thing, greater than 2 millimeters during exercise or recovery. Recovery is very, very important with EKGs because we can see a lot of what's going on with the heart. Or what we call, this is a fancy word that you might not know, chronotrophic incompetence. Chronotrophic incompetence. We see this all the time in cardiac rehab. So chronotrophic incompetence is presence of abnormal hemodynamics during exercise. These are the patients where systolic blood pressure, heart rate is not doing what it should be doing. It's not coming down. It's still, the heart rate's still tachy. So we call that chronotrophic incompetence. Whoops, sorry, my cursor slid. So any one of these would put them at a high risk. And then the next slide is more non-exercise related. So low ejection fraction, less than 40. This is someone who had a cardiac arrest, so they've been brought back by using the paddles. They've been cardioverted. Complicated MI, complicated stent or open heart surgery. They have heart failure. They still have ischemia. They have depression. So this is what we call low, moderate, or high risk. And why am I sharing this with you? Because think about this. This class is for working in a clinical setting. Everyone has known disease. Just because they have known disease, we still want to further risk stratify them so we understand their disease and how much we really need to be watching them a little bit better. So this is a lot of information, some of it which you may already have known. This week, I want you to dig into metabolic syndrome. I want you to explain it in your own words. I want you to come up with a public health message as to why we're even concerned with this. I want you to explain 3 complications that happen from diabetes. Go back, the answer's in my slides, diabetes, full-blown diabetes. And share something that I mentioned. It might be chronotrophic incompetence. It might be silent ischemia. I want you to share something you never had heard of before in your assignment this week. Thank you. Remember, if you want to talk with me over the phone or with a Zoom or text, you can find me. I want to make sure you're not feeling lost in this online class.